All right, great. Well, so this is always the hard talk because it's right after lunch and I saw the lovely carbohydrates, so I will try to keep you all engaged. I really want to thank you all for letting me come. I think, these symposiums are so important because you all are the real grassroots people that are the ones that make these changes and help us to do a good job with our patients. I also want to thank you for inviting me here at this time of year. When I left my home in West Virginia, it was 10 degrees, so it was lovely to come and be here, although you're welcome to come visit me in August when it's like 110 degrees here. All right, so let's talk about this lady. So Mary Margaret, right, 65-year-old woman, she's got some comorbidities. She's a retired teacher, but she's functionally very, very independent, right? So she walks, she does Zumba, she fosters, of course, is the nicest lady in the whole town. She's raised up troubled teens and volunteers at the homeless shelter and makes soup and all this stuff, right? And so she's voted in the community to be the nicest lady and the most likely to get into heaven, right? And all you nurses know that that is a bad prognostic factor, right? That is not good. You do not want to be that person. And so she shows up to the ED and she's got 5 days of right upper quadrant pain. She's febrile. She's a little confused and altered. She's oliguric. She's got acute renal failure. And she's got a white count of 22,000, right? So this is no surprise. It's not going to sneak up on you what the diagnosis is, right? She's got the sepsis, right? And when you get the sepsis, this is bad, right? Mary Margaret is in a bad way. And so she goes through and they do all the sepsis things appropriately. They get source control, you take care of her cholecystectomy, wean her off the pressors, renal function's improving, she does get a pneumonia, and then she ends up with a tracheostomy. She's in the ICU for about 2 weeks, but now her mental status is improving. She's been off pressors, normal lactate, off the CRRT, her urine output's good, and she's improved from that standpoint, right? And so I'm going to challenge you to think about all the things that we tend to not address. We're good at the sepsis bundle. Man, we are on target with antibiotics and fluid and hitting things up front. We're really good at studying acute illness, mortalities, readmissions, right? Our target goals, our bundles. We're really good at investing in pharmacology, right? 'Cause we are great about it. If it costs a lot of money, it must be great, right? So we got to spend money on that. We're really good at looking at the upfront. What we're not so good at looking at are some of those other things that have been underappreciated for a long time, right? And so here's Mary, and I don't know that you could see, but I'm sure you've seen patients like this. They're very weak, they're laying there in their bed. You ask them to raise their arm up, they can barely move a hand. You ask them to lift their leg up, they can kind of flex their feet, right? You've seen these patients in the unit. You ask them to get up and sit in a chair, well, you have to do the full lift, right? And so this is what tends to happen with patients for a variety of reasons. And there are some predisposing factors. So we know that there's a spectrum of disease, like anything else, where you can get ICU Acquired Weakness, which happens when people are critically ill. You can increase that to a Critical Illness Myopathy, where they get weakness and you actually get loss of some of the muscle tissue and it gets infiltrated and replaced by fatty tissue, right? And then it can go all the way to Critical Illness Polyneuropathy, we actually get damage to the end motor axon, right? And they can lose sensory and motor function and actually permanently inhibit some of those nerves, right? So like everything, there's a gradation of what can happen. And some of this, she's at higher risk because of the sepsis, right? But there are some other factors that put these things in and make them a higher potential of occurring. So we know sepsis is a huge predisposing factor to all of these things, ICU Acquired Weakness, the myopathy, and the polyneuropathy. We know that hyperglycemia and the number of days spent hyperglycemic increases that chance. If they have multi-system organ dysfunction or failure, adds to that risk, right? But immobility and bed rest is an independent cause and can contribute to this, okay? Corticosteroids, use of neuromuscular blockades, and sometimes we have to use these things, right? But there are some things that we can control for. And changing our view on the importance of mobility in the ICU is so incredibly important. And I hope by the end of this talk, you also agree with me on this. There was a time in a day when you would walk into an ICU and the only good patient was a patient that was laying there in their bed, not moving, that God himself couldn't get a response out of, right? Those days are really changing, and we need to be engaged in getting people up and about more. So this was very interesting. This was a study that looked at what is the effect on bed rest itself. And this was done in Europe, right? And they took healthy volunteers in their mid-20s, early 30s. They could have no comorbid conditions. They were not acutely ill. And they put these people in bed for 30 days. And they compared that to the other patients that were out doing their normal activities. So just in that time, bed rest alone, right, 4 to 5% loss of their muscle strength for each week that they were on bed rest. Every patient developed insulin resistance. Every patient. And then you could see the change. This is the MRI. The top one is the MRI of one patient at the beginning of the study, and the bottom picture is the MRI at the end of the study, right? And what you see is that loss of muscle and the fatty infiltration. So these are non-acutely ill people with no comorbidities who just were on bed rest alone. That's really powerful that that can happen. So what can happen? You could actually lose some of the myosin, where they change from slow to fast twitch fibers. You start changing the metabolism of the cell, right? You start seeing protein synthesis dramatically decreased and a big increase in overall of some of your inflammatory cytokines. And you also see the contribution, just with bed rest alone, that increased cachexia and cellular apoptosis. So I'm going to break down for you a little bit about what is the difference between some of these different disease states, although they all fall under the diagnosis of weakness, right? So an ICU acquired weakness is what you will commonly see, and this is just that diffuse generalized weakness, but their sensory and motor, their sensory nerves are all preserved, and their motor nerves are still actually intact. So there's no structural change to the nerve. It's just the muscle weakness. And this can happen in up to 25% of your mechanically ventilated patients, right? So increasing risk factors, again, if they are also on steroids, neuromuscular blockade, and sepsis. And this, I think, is very telling, and this is what I use with my patients quite a bit, that for every day that they're on bed rest, you can lose almost 1.5% of your lean muscle mass per day. Right? So when you have the family member who comes in, oh, but it was such a big day. They've been through so much today. They just seem so tired, right? And you all have to deal with that at the bedside, right? Because you don't want to make it's important. Tell them, look, for every day that they are not getting up, standing, dangling on the side of the bed, we are losing muscle mass, and that's going to affect their long-term outcome. And it's not uncommon if in mild states for this to take several months for them to get better. And if they get severe, you can still have issues even out to 5 years. Well, that's really impactful when you start thinking about not just today and are they uncomfortable today, but you're thinking long term and what's this person's outcome, and is he or she going to be able to get back to work? Or, more importantly for many of our older patients, is he or she going to be able to get back to independent living in their home, which for many of our geriatric patients is really important. Right? So the impact. We know when you get ICU acquired weakness, there's an increased mortality, increased readmissions to the ICU, increased events such as failure, mechanical respiratory failure because of the weakness, right? And lower quality of life scores at 6 months after they've recovered from their acute illness. Critical illness myopathy, you see a lot. It affects the legs more than the upper extremities. You'll see this flaccid quadriparesis. They do have preservation of the sensory nerves, but it's almost as if they are almost like a quadriplegic patient. Facial muscles may or may not be involved. And when you actually do an EMG, you'll see diminished amplitudes in the muscles. Right? you can actually see this look like rhabdo. So you'll actually get muscle breakdown and the CKs can be elevated. And that's one thing that differentiates it just from ICU acquired weakness. And here you can see a patient who had, again, at the top and at the bottom, you see the difference between what it looks like between a normal muscle fibril and then down below where you have a patient who has critical illness myopathy. And there are true structural changes that are happening to the cell and to the tissue. And then the worst and the longest lasting impact one is the one where you develop a critical illness polyneuropathy. Neuropathy. I'm sorry, I keep wanting to turn this into a kidney talk, sorry. And I really don't like the kidneys at all. So, however, in this, you actually get ischemia that occurs in the axon, and so you get degeneration at that area where the nerve is innervating the muscle, right? And you'll not only get limb weakness, but you have some of the atrophy, and you also can get sensory losses. This now starts to affect the reflexes, and they lose some of that peripheral sensation, which can be long-lasting and may not come back at all. So how do you prevent this? One way that you can decrease the risk of this, or possibly prevent this, is early mobilization. And when you look at some of the different papers, what does that mean? That means within 48 hours of admission to the ICU. Now, I'm not saying take the person who has ICPs of 70 and the person who is on 5 pressors and tell them they got to get up and walk around. But those patients could be doing some active or passive range of motion, right? And I think we tend to, because it doesn't come in a bag and it doesn't have a pill and you don't have to barcode it, right? A lot of times this tends to get forgotten. But just doing active or passive range of motion in some of these patients can help decrease the chance and keep those muscles engaged. So having a progressive plan so you don't lose track, right? Dangling at the bedside. The nurses were so profoundly correct and we've forgotten, right? This whole thing used to go into an ICU or go into somewhere and the nurse would be, we got to get them up and dangle. 5 a.m. in the cardiac unit, the nurses had those patients sitting up at the side of the bed. Now, I don't know how many of you pay money to go to a gym. How many of you pay money? How many of you go to a gym and do core exercises, right? So you're paying money to do core. This is core exercise for an ICU patient. It's incredibly important that just sitting at the bedside, holding their torso up is very important. You can get some other devices. You can do like a little hand cycle. You can get them at Walmart. You can buy really expensive ones that are hospital grade, right? But there are different things that you can do. There's progressive tilt tables where they can push up on their weight bearing and actively strengthen their legs. But really cheaply, when you sit them up in the chair, tell them to lift their leg up 100 times or 10 times every hour. And think about if you were to do that sitting in your chair and every hour you did a straight leg lift, right, just sitting there in the chair, how much stronger your quad would be, but we forget, right? So here's Phyllis, and this lady, what she's on is what's called a Moveo. And this tilt table, you take out a bracket, and then she can gradually push down and then push up. And it's a way to re-strengthen. It's an expensive piece of equipment, but rather than try to have her stand up and trying to do squats standing there, you give her support by having her just push against her own weight. And it gets those quads engaged in the calves, because remember, those are going to be more affected and first affected compared to the upper extremities. Right? But like I said, even if you don't have a fancy expensive table, just having them, you remember the old sports medicine adage for sprained ankles. Use your toes like a marker and write out the ABCs. Well, you're moving the calf, right? Sitting there raising the leg up or pulling their knee up to the sky. Or giving them the little bungees to do on their chair or in bed. Or give them a hand grip to squeeze. All those things keep those muscles engaged, right? And then help prevent some of this weakness. So then the question is, does this make a difference, right? Because we all know that we're all running short, and one of the first things that gets cut are the things that, quote, don't generate money. And so having mobility teams and dedicated PT in the ICU can be a real challenge because they say, whoa, we can't generate a big bill for that, and that's hard then to get the FTEs for that. But this was a big study that looked at, early mobilization versus standard treatment, meaning just kind of getting them up when things looked better, right? And again, early mobilization was at 48 hours. And the return to functional status at discharge and the need to go and go to a rehab versus being able to return home was substantially different. But look at the other things that really do affect the bottom line. Decreased delirium. And I'm sure you've talked about delirium, and I'm sure you're going to hear more about it in the next talk. Right? Delirium, every day they're delirious, adds to the cost of that hospitalization and decreases their cognitive outcome at 6 months. Right? Decreased mechanical ventilation. And look at the times on these. It is substantial. And this isn't a wonder drug, and it's cheap, but it does require effort. It doesn't always require a physical therapist, but it does require teamwork at the bedside between the doctors, the nurses, and then for the advanced things, the physical therapist. In fact, it's thought to be so important that it's actually part of an ICU bundle. And I'm not going to go over this too in depth because, again, that's the whole next talk. But it is important. And this is what I hear all the time, right? And when we first did this at our institution, oh, Dr. Wilson, our patients are so sick. You don't understand. And they're like, oh, but they're intubated. What if the tube falls out? Or what? Oh, they got a femoral line. My God, we can't do anything there, right? And so, then you have to, oh, my chief says they're too sick. Or, oh, the family's stressed and they want him to rest. And this is where I say, well, if you want him to go home with you alive and not dead, then we need to do this, right? So there are multiple trials that look at the safety and the impact of doing active mobilization when they're mechanically ventilated. In fact, there's 9 randomized controlled trial, right? And in the mobilization groups, they all do better, have better outcomes, but with a very, very low complication rate. So if you do this as a group and you work together and you're cooperative with the patient, and you have an awake patient, that's the other part of this, then you'll find that they can get extubated soon, get up, mobilized, and prevent some of that weakness. And what do we mean by mobilizing? Right? Again, for some patients, for that sick patient, open belly, on pressors, it can just be passive range of motion, but it's still engaging those muscle groups and keeping them moving. Active range of motion, and that can be complicated with some kind of machine that you have, whether that's a hand cycle, whether like on the bottom picture, there are these mobile leg cycles that you can get, right? And that's great if you have access to those. But again, sitting them up and just coaching them, or in fact, engage the family. So many of them desperately want to have something. And you as the bedside person need something to keep them engaged, right? Because if not, they're out there, every time they cough, they're out there coming to get you saying, oh, they're coughing, right? Give them some homework. Engage them in their loved one's care. And tell them, hey, 10 times per hour, have them squeeze the ball and lift their leg up, right? And they're doing something for their loved one. And you'll find that degree of engagement, they'll do it. It's not that you have to do it. They'll do it and they'll be appreciative that they can help their loved one get better, right? Sitting up in the chair, dangling. And the big marathon for somebody who's been really sick is that stand up, even when they're intubated, transfer weight, turn, and sit down. That's like running a 5K if you're a really sick ICU patient. And that's a tremendous goal to try to get to, as opposed to they passively lift them up and put them in the chair. So what are the barriers to mobilization? One of the biggest barriers is just underappreciation that this is important. Again, you get hammered on about, did you fill this out on the flow sheet? I'm sure almost all of you have EMRs, right? And I'm sure your EMR, you're duplicating your documentation and you're spending about, if you're like many other places, 50% of your time typing in the computer compared to doing bedside care, right? So that's a real barrier, and people tend not to appreciate the importance of it. Lack of physician engagement. If the doc doesn't think it's important, you could do 6 months of education, and your first physician leader who comes through and says, well, I think that's dumb, boom, the whole project's dead. So this is where you really need your physician leaders engaged and understand it. Lack of PTOT staffing, right? But this is where if you could design a team and say, this is what nursing staff and CAs can do, and this is how we're going to do our PTOT in the units, you can overcome that. And then lack of structure. So what can we as physicians do about it? Well, one thing we can do is think about mobility every day. Put it on your checklist. It's a great program out of Hopkins called the 6 Clicks. I encourage you to look on it. It's a very quick, easy assessment. It gives you sort of 6 quick things to assess what their functional status is, and then you can gauge your PT resources, right? Review the orders every day. When we did this at our unit, almost 50% of our patients in our MICU had contradicting orders. Bed rest, lay flat, get up, roll over, walk around, right? And the nurses are like, I don't know what to do. And so you err on the side of, well, I don't want to hurt them, so that must be make them lay there, right? But in fact, what I want you to do is I want to change your mindset. I want you to think of, hey, having them lay there is actually the most harmful thing, right? And get those docs engaged on doing that. Minimize your sedation, right? They should be awake, writing notes to you, playing checkers, right? Avoid benzos, screen for delirium. Again, you're going to hear more about it. Early involvement of PT and OT, get those assessments in. Therapeutic activity orders, that's what we do. And that enables your nurses, right? So the poor nurse, well, God bless the nurses is all I have to say, right? So there they are, they've got a patient, they're frustrated, they're tired, they don't feel well. Maybe you have a family member that's been in there a week and they haven't gone home and they're tired and cranky, and you're like, okay, time to get out of bed. And they're like, I don't want to. And they're like, oh, let them rest, right? And here you are trying to say, no, we really need to do this, right? But if the doctor puts in a therapeutic order, you can say, look, right here, the doctor says you have to, right? This is right next to you. This says you have to do this. Says you can take medication for pain. That's a maybe. But you have to do this, right? It enables you to be able to uphold that a little more and get patients moving. And so what I found is that people, if you give it a really corny name, people tend to have more buy-in. So we have this program we called Mobility Miracles, and everyone rolled their eyes. Oh, Dr. Wilson, you come up with the corniest names, right? And what we did was make mobility a focus. And so what we did was we said, okay, here's our patients. And like every other PT time, what we were finding happening was PT would come to the bedside, and the nurse had just gone to take care of something with another patient, and now you spend 45 minutes of that hour undoing spaghetti lines, and then you got to get their pain meds and stuff. So we made it a set time at the beginning of the day and said, here's the patients, Mrs. Jones at 9, Mr. Smith at 10, etc. And so the nurse knew, hey, at 9 o'clock, at 8:30, I got to get pain meds in, and I got to get my lines untangled, and I need to have this ready to go. And it was such a good satisfier for both PT, the patient, the family, and the nurse. It's not a hard thing. It cost no money. It was just organizational. But it made a huge difference in the amount of time that they could then spend actually doing therapeutic activity, right? And then it let everybody play on their day. And then we had to empower our nurses to tell the resident, because invariably Murphy's Law is that's the time they're going to want to come over and change the dressing or pull the chest tube out, right? And that time was sacrosanct, right? They couldn't go get a CAT scan then. They couldn't go down and get their standing upright films. And that's just when you had to do that. And so what we found was that by having these preset, sort of escalating things, we were able then to communicate with signs to our patients. Hey, this is what they're going to do. And your PT time's at this time, right? And we could clarify those roles. And then we were able to better utilize our support equipment too. And you had to have a big multidisciplinary approach to this and buy-in across the unit from all the leaders, nurses, physicians, PT, OT, respiratory. And we added it to our checklist. And what we found was that it was a huge impact, right? And now our patients tend to be a lot more awake and more interactive, and we definitely see better outcomes. And we actually have patients walking around our unit intubated. So I thank you for your time. This is what West Virginia looks like for those of you who haven't been up there. And appreciate you letting me come to the nice warm area.